everyone. Welcome to OsteoBytes. Thank you so much for joining us today. We'll give a few seconds for us all to gather in our virtual room. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBytes, we are joined by Dr. Chelsey Burke. She's one of our 2024 OutSmarting Osteosarcoma Young Investigator Grant recipients because of AVA, and she will provide an overview of her funded work on understanding tumor evolution in osteosarcoma. Thanks so much, Dr. Burke, for joining us on OsteoBytes today. We are thrilled to have you. And thank you also to our panelist, Walker, for joining us. Always happy to have you. Everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Burke after her presentation. A little bit about our guest today. Dr. Chelsey Burke is an assistant attending and young investigator at Memorial Sloan Kettering Cancer Center, though soon to be moving to Stanford University here on the West Coast. After graduating from the University of Iowa with a BS in biology, Dr. Burke obtained her medical degree from St. George's University School of Medicine. And following pediatric residency at Advocate Children's Hospital in Chicago, where she served as pediatric chief resident, she joined the combined Memorial Sloan Kettering and New York Presbyterian-Weill Cornell Pediatric Hematology and Oncology Fellowship Program. During fellowship, Dr. Burke joined the laboratory of Dr. Filemon Dela Cruz and Dr. Andrew Kung, where her research focuses on pediatric cancer modeling and preclinical drug development. Dr. Burke has a particular interest in bone sarcomas, including osteosarcoma, and is involved in the preclinical evaluation of several novel therapeutics. She hopes this work can be translated into early phase clinical trials and ultimately improve outcomes for children, adolescents, and young adults with high-risk sarcomas. Thank you so much for joining us today, Dr. Burke. We are very much looking forward to your talk. I just have a few announcements before we get started. We are winding down 2024. In fact, this is our last OsteoBytes of 2024, but we are getting ready for all that is to come in 2025. In particular, please save the date for our Factor 25 conference, which will be June 26th to 28th at the Grand America Hotel in Salt Lake City. Abstract submission is now open. The submission deadline for abstracts is January 10th. You can find that on our website. I'll put more info in the chat about that. Travel award applications will also open soon in mid-January, and then registration will open in February. So be on the lookout for that. Other things to look forward to in the new year, we have our next Turbo meeting, which is our tumor review board for osteosarcoma. Next meeting is going to be January 8th at 5 p.m. Eastern. And again, I'll put more info in the chat if you're interested in presenting a case or just want to attend. Also, Child Cancer Action Days is going to be in February in Washington, D.C., and MIB Agents is assembling a team to represent on the Hill. So if you've ever wanted to share your story with a congressman or congresswoman, it's a great venue for doing that. There are several key policy issues that impact children with cancer. So we want a really strong showing of support and advocates at Action Days. And sharing your story with members of Congress is a great way to ensure that the voice of children with cancer is heard loud and clear. The Alliance for Childhood Cancer, which helps to organize this, has a limited number of scholarships. Applications for those scholarships are due January 6th. So I will also put a link in the chat with more info on that. And lastly, just kind of a heads up, we are accepting applications for our 2025 Junior Advisory Board starting in January. Our Junior Advisory Board is really the heart of MIB Agents. They help make sure we are focused on patient-centric initiatives, and they really serve as powerful advocates. They share their patient perspectives with the scientific community, as well as regulatory and legislative groups. So more info to come, but if you know of an AYA osteo warrior or sibling who might be interested, please give them a heads up and we'll have more info about that in January. And speaking of, Walker, who's joining as our panelist today, is on our Junior Advisory Board. He's been our Junior Advisory Board Vice President, I think, in past years. So we are so happy to always have him on OsteoBytes. Walker, could you please introduce yourself?
Yeah, of course. Hi, my name's Walker. As Christina said, I've been on the Junior Advisory Board for the last few years now, and to anyone who's thinking about it, I highly recommend. It's been a great experience, and I think this is probably my last year, so definitely sad to go, but I plan to stay involved with MIB for as long as I can. More about the presentation today. I had the chance to look at a sneak peek of the presentation And PDX models always really kind of fascinate me. So I'm excited to hear more. And Dr. Burke, you can take it from there.
Great, perfect. All right, let me share my screen.
Perfect. That looks great.
Excellent. Okay, thank you so much for having me here today. I'm really excited. As they've said, my name's Chelsey Burke, and I'm a pediatric oncologist on the faculty here at MSK, and really excited to talk to you about my project, which is evaluating tumor evolution and mechanisms of resistance in osteosarcoma. So osteosarcoma is the most common primary bone tumor that we see in adolescents and young adults. And when it's localized, chemotherapy and surgery can cure about 60% of patients. However, there's still a large percentage of patients that will have metastatic disease at diagnosis. And we know, unfortunately, that these patients with metastatic or recurrent disease still have pretty poor survival outcomes. One of the biggest advancements in the treatment of osteosarcoma was the inclusion of systemic chemotherapy in the 1970s. And after this implementation, we saw a dramatic increase in survival rates. However, you can see that this improvement that we initially made has essentially plateaued over the last several decades. And this inclusion specifically of MAP chemotherapy did not and has not improved survival rates for those patients with metastatic osteosarcoma. So this has really remained unchanged. We haven't been able to make improvements upon this over the last 40 to 50 years. So this just to kind of remind everyone is the basic schema for that 3-drug MAP chemotherapy regimen that we're talking about. So treatment follows a multidisciplinary approach. So this includes first preoperative, or what we call neoadjuvant chemotherapy. And this is given before surgery and consists of 2 cycles of doxorubicin, cisplatin, and high-dose methotrexate, followed then by definitive resection. And then post-operatively, we give kind of consolidative or adjuvant therapy. And the rationale here is really to eliminate any residual microscopic disease that might still be present to hopefully reduce that risk of recurrence or metastasis. And so with all that we've learned, over the past couple decades about, the genetics and the biology of osteosarcoma, one thing that we haven't really looked at yet are what are the effects of the chemotherapy that we're giving? Like what is MAP chemotherapy actually doing to the tumor cells? And why is it that we see that some patients respond to MAP therapy while others don't? And what is it in a tumor that makes it more likely to recur or to spread than another tumor? And so one thought here is that there are these pre-existing cells in a tumor that are either inherently resistant to treatment or that go on to develop resistance over time. And so this picture here shows these cells are thought to represent kind of a small proportion of the tumor early on. So small, in fact, that we're really just not readily able to detect it by the imaging that we currently have. And then over time, while treatment may kill off a majority of the sensitive cells, this initially, very small subpopulation evolves and grows. And it's this resistant subpopulation that eventually, takes over and goes on to metastasize. And so this here is another depiction of this kind of same general idea. And this comes from a publication a year or so ago of the work done by Dr. Michael Kinnaman, who I think has presented at OsteoBites previously, so some may be familiar with his work. But he showed in osteosarcoma patients that there are these small subpopulations of resistant cells, again, either inherently resistant or that go on to acquire resistance, that can emerge and go on to kind of be the dominant population in recurrent and metastatic sites. And while the chemotherapy we have does a fairly good job of killing most of the tumor, this small population of cells that we fail to kill off with the treatment that we have is what ultimately will end up being lethal to the patient. So what does this subpopulation look like? How does this population of cells evolve or change with the treatment, the standard of treatment that we give, is the primary focus of my study then. But taking a step back, even a little bit further, how do we even know that these subpopulations, how do we even know about these subpopulations? How do we know that they exist? So traditionally, genetic sequencing kind of takes material from a whole population of cells that's pooled together and then sequenced as a bulk sample. So what you get here is really just an average of what is going on in the tumor. That's why kind of with our traditional bulk sequencing, we typically don't have the ability or the sensitivity to see those small or rare subpopulations. And over the past several years, as sequencing techniques have become more sophisticated and less expensive, we now have the ability to interrogate the genome of single cells. So with the application of this single cell sequencing, we're now able to detect and characterize those small subpopulations that were being missed before. So work that's being done by people like Dr. Filemon or Dr. Jovana Pavicic, who some on this call may also be familiar with. They're using this sequencing technique to look at osteosarcoma samples and to look at samples that come from an individual patient, throughout the course or at different time periods over the course of their treatment. So, we're starting to gain insight and now can more readily access this technology that allows us to study these subpopulations. And so as a result of this work, that kind of brings me to my project, which is evaluating tumor evolution to treatment in osteosarcoma. And this project is really driven by the hypothesis that there is a small resistant cell population that arises through selective pressure when we give MAP chemotherapy. And if we can study this population, we will be able to identify dependencies or vulnerabilities in these cells in order to target these subclinical populations and hopefully overcome or reduce the metastatic potential of these tumors. And so there are three main phases or objectives of the study that I'll go over. The first of this is going to be describing the effect of giving MAP chemotherapy on these tumor cell populations. And we will do this using osteosarcoma PDX models, and I'll go over that shortly. Next, once we're able to characterize these tumor cell populations, we can then apply different computational approaches in order to identify therapies that could specifically target those resistant cell populations that emerge. And then finally, the last step will be then to validate these therapies in our models. So in order to study how MAP chemotherapy affects the tumor, our lab uses mouse models. So these are what we call patient-derived xenografts, or PDXs, that are created from a patient's tumor. So we take the tumor from a patient, process it, and implant it into a laboratory mouse. And here at MSK, we actually have a number of osteosarcoma PDX models that were created from the same, from an individual patient, again, at various time points throughout their disease course. So from a single patient, we can generate PDXs from tumor material, say at diagnosis, before they've seen treatment, after they've seen MAP at definitive resection, and also from sites of metastatic disease. And then at all these time points, we're able then to study the genomics of these tumors and see how they differ or how they evolve over time. So the first part of this project is going to be taking the diagnostic tumor samples that we have, implanting them and expanding them in mice, and then seeing what happens when we give them MAP chemotherapy. And we'll, once we've given them MAP, resect their tumors and perform a number of different kind of analyses on these tumors to see how these agents have changed these tumors and what changes we see in these treated tumors. And then what we want to do is take all this information that we've learned and these drugs that we've been able to identify and incorporate it early into treatment to hopefully eliminate those subclinical population of resistant cells. So to do this in PDX, to do these PDX studies, we have to use immunodeficient mice. And so these are mice that have defects in their immune system, which allows for the tumor tissue to grow. And because of this weakened immune system, it can often be difficult to give them chemotherapy because they just don't tolerate it well. So an important step for all of this study is to make sure that we can actually give a cycle of MAP chemotherapy in our mouse models. And so we want to try to replicate this treatment regimen as closely as possible as we can in our mice. And there's work that has been done by colleagues at St. Jude where they've been able to determine the clinically relevant dose in mice. So this is a dose that would essentially be equivalent to, in the mice, to what humans get. And if anyone has experienced MAP chemotherapy or knows someone that has received the chemotherapy that we give, it's actually quite toxic. And so in order to mitigate some of these toxicities, we also need to support our mice with things like extra fluids and leucovorin, just like we do in our humans. So it can be a difficult process, but to enable us to give clinically relevant dosing, the first thing we have to do is conduct tolerability studies in the PDXs. And so we treat a number of mice at a couple of different dose levels, and we monitor their weight over time. And this kind of serves as a marker for how well the mice are tolerating the treatment. So you can see this graph here is just kind of plotting percent weight change from baseline throughout a cycle of MAP chemotherapy. And so in general, the mice tolerated this one cycle of MAP fairly well. And we typically use kind of a cutoff of around 10% or less of weight loss as being acceptable. And so in one mouse that was being treated at the highest dose level, they initially did lose more of that, but actually were able to recover most of that weight by the end of the cycle. So we see that with supportive care, with fluids, with leucovorin, the mice were able to tolerate MAP chemotherapy. And so now that we've confirmed that we are actually able to give clinically relevant doses in mice, the next step is then going to be to treat and study our PDX models. So again, we'll take the tissue that's derived from tumors from diagnosis, so that have not been treated with chemotherapy, and treat them with that cycle of MAP. And we want to study, again, how these tumor cells change over time with the different agents that we're giving them. So we will take a cohort of mice and analyze their tumors at a couple of different time points. So this first time is going to be after the mice have seen cisplatin and doxorubicin. So the first part of MAP. And then we'll take a second cohort of mice that have seen all three of these drugs. So after they've also seen methotrexate, and then perform a number of analyses and kind of compare what we see and what has changed. At these time points, then we'll plan to image the mice. So, much like humans get doing PET CTs to get an idea kind of tumor size and initial response to therapy. We'll also look at things like cell viability and proliferation and, the amount of cells that have died off. We'll, do the single cell profiling analysis that I talked about, as well as another type of analysis, which is called VIPER, which I'll explain in the next couple of slides. So, after treatment with these various agents, what do we expect to see? So we anticipate that there, again, are going to be changes in these subpopulations of cells pre-treatment compared to after treatment. And it's these, subpopulations that survive that represent, again, those resistant cells that eventually go on to spread and to metastasize. So by identifying that resistant subpopulation that emerges during treatment, then the second aim of our study is to apply this computational approach in order to identify therapies that specifically target that resistant cell population. And in order to kind of explain the rationale for this computational method, it helps to kind of take a step back and talk about some important concepts. So the first concept is that of a cell state. And this is really, the notion that any cell, whether it's a normal cell or a cancer cell, has to maintain a very specific set of protein interactions in order to maintain itself in the cell state. And any changes in these interactions, in some instances, can result in a pathologic shift from a normal cell to a cancer cell. But the basic idea here is that, again, for a cell to maintain its identity, it has to really maintain a strict set of protein interactions. And in order for a cell to maintain its state, there's this hypothesis in cancer cells that these interactions sort of converge into just a few critical nodes at this cancer bottleneck. And it's these few specific nodes that are responsible for maintaining the whole cancer cell state. These nodes at the bottleneck here are proteins, and they've been termed as kind of these master regulators, again, because they're the proteins that are responsible for maintaining the cancer cell. So we work with colleagues in the Andrea Califano lab at Columbia University here in New York, and also with other physician scientists like Dr. Pavicic, who have then gone on to develop computational approaches to identify these critical master regulator nodes. And so the thought here is, if we can identify these master regulators and then target them with drugs, we could theoretically knock out and kind of collapse this entire cancer cell system. So by targeting these master regulators, the cancer cell wouldn't be able to, maintain its identity, and the consequence of that is cell death. And so this computational approach and this hypothesis has been validated in a number of different cancers listed here, and has also led to several different clinical trials. So work in pediatric tumor types in our group, like in some pediatric renal tumors, has even led to the development of a pediatric clinical trial here at MSK. So now we want to take and apply this method to identify and target those master regulators that are responsible for maintaining those resistant cells that emerge following treatment with MAP chemotherapy. And so applying this computational method, this is called VIPER, specifically to that resistant cell population, what it will be able to do is ultimately generate a list of these top master regulator targets. And then we can take drugs, that already exist, that may be, FDA approved for other indications, and match them to these targets. And so we hypothesize then that this list of master regulator proteins that we see one, are probably different from the regulators that kind of dominate the pre-treated tumor. And they also represent targets that are not intrinsically, sensitive to the drugs in MAP, because that's how they've, been able to survive. And so after we've identified these master regulators and the drugs that target them, then the final phase of our project is to validate drugs that will target the master regulators in that resistant cell population. And so if we're able to target these resistant cell populations, this is how we can, identify, again, existing therapeutics that we can combine with our conventional therapy, with the hope of kind of preventing treatment resistance and recurrence, and preventing that escape of micrometastatic disease that's so lethal. So we'll be able to go back to our PDX models, and with the addition of these new agents, compare how tumors respond when we treat them. And we then anticipate that if we're able to, better target those resistant cell populations early on, and can validate them in our mouse models, then we'll be able to take and incorporate these new therapies, back into our patients, because that's, ultimately the main goal of all the research that we do, is to find, more effective treatments, and to make it better for everyone that's affected by osteosarcoma. So we're still in the early stages of this, project now, and we plan to start, finally treating our models in the next few weeks, hopefully right after the holidays. And so I'll be, very excited to update you all with more of our results at the Factor Conference this summer. So with that, I'd like to give a special shout out and a special thank you to Osteo Warrior Ava Levin and her family, who have supported and are supporting this research. And of course, none of this would be able to be done without, the other patients that we see here at MSK, and everyone in the lab, and at MSK Kids here who supports this work. So thank you so much, and we can open it for questions.
Thank you so much, Dr. Burke. That was thank you for breaking that down. That kind of just made it like easy to digest. So I appreciate that. Everyone, if you have any questions, please feel free to add them to the Q&A. We actually have some nice time to get into some discussion and questions, which is great. Walker, I think you might want to kick off the Q&A.
Yeah, I have one question. So, and you may have already said this and I just completely missed it, but when it comes to the master regulator proteins, so let's say you have metastatic disease, would it be different for each individual tumor site, or is the master regulator protein going to be the same for all those?
That's a really good question. And we're fortunate that we do have, those patients that have multiple sites of metastatic disease. So that's, kind of one of the questions that we hope to answer. In some work that's already been done, we do see that some of those proteins are conserved, between the different sites. And I think, we all know that osteosarcoma is like very complex, and the genomes of it is very chaotic. So there can be some differences, but we definitely see that a lot of the same master regulators are preserved between samples. Yeah.
Okay. All right. That's good. Thank you.
Yeah.
Do you want to take that question that just came in, Walker?
Oh, did it? I don't think oh, okay. I see it. The question that just came in says, thank you for a great talk. How uniform or consistent are the tumors in the PDX mouse model? Also, how important is the lack of immune system as a confounder?
Yeah, so I'll start with the lack of immune system. So there are different types of mice that we use for different studies. And so the parts of the immune system that we kind of knock out can be different, and can change depending on what we're studying. So the lack of immune system here in the osteosarcoma it shouldn't be too much of a confounding factor. We try our best, and these PDX models are a pretty good recapitulation of the tumors, that we see in patients, but of course, not everything's going to be perfect. It's hard to kind of replicate exactly that tumor microenvironment. So it's something that we have to consider, but overall, in studies where we have compared patient tumors to the PDXs, and then the different generations of PDXs that we create, there's a little bit of kind of genetic drift that happens, but it's really kind of one of the better models that we have in order to kind of do all of these, drug testing, which theoretically couldn't be done, in patients directly.
Yeah, that makes sense.
That answered it.
Dr. Burke, I have to ask you actually about thank you for kind of explaining actually how you are able to administer MAP to the mice, because, well, I know it's actually really important, right? Because I feel like I often come across papers where they're trying to somewhat kind of mimic the patient treatment experience, but ultimately they can't, because, it kills the mice, right?
Mhm.
So I actually think it's really impressive that you're able to administer MAP and provide that supportive regimen. And have you guys published or shared anything about that supportive regimen? Because again, I don't know that, I don't think it's common actually for people to.
No, actually, like I had mentioned, colleagues at St. Jude have looked at this in their PDX models, but really there's not any published data on this, because we really just haven't looked at MAP chemotherapy before in our mouse models. We know from back in the 1960s and 1970s that these agents are effective, but we really haven't studied how what's happening when we to these tumors when we give it. So no, it hasn't been published yet. And so that was a big first step in this project, is just being able to make sure that we can again replicate it with the kind of mouse equivalent dosing, and determine how much supportive care that they need. So right, like I said, right now we've been able to give them 1 cycle. I know that we want to go on and eventually, I think it's out of the scope of this project, but incorporate other agents or multiple cycles of MAP, and again see how these tumors continue to evolve.
Yeah, I just think that could be really helpful for the research community, just on
Definitely.
how you're able to kind of give these mice MAP. So question about because as you so nicely illustrated in your cartoon, so there are some localized primary tumors, right, that you treat with MAP, and then they're done, like there's no recurrence, no relapse. And so in those situations, is it just because there are no chemo-resistant subclones that develop for whatever reason?
Yeah, I think that's probably what is happening, that the chemotherapy that we do give is able at least to effectively kill all of those populations. And they're whether it's going to vary between patients, whether those subpopulations of cells, like what different mutations they go on to acquire. And so if one patient's tumor really doesn't acquire that at the beginning, and when we're able to effectively kill off all those cells, then we are kind of eliminating all of those populations, or they're sensitive to the treatment that we give.
Got it. So it's kind of a combination of both, what cells kind of exist prior to then, to what extent they evolve after given MAP.
Yeah. And in certain tumors is the treatment that we are giving kind of actually driving this small population to then expand and grow.
Yeah. And so what about the difference between MAP, which I know is most important because it is kind of like the standard of care, but what about looking at this in other kind of common chemo combinations for osteo, like ifosfamide etoposide or
Right.
gemcitabine docetaxel.
Yeah.
Steve, is that somewhere on the roadmap to see?
Again, yeah, that is a goal of all of this. I think, you know, here it's first to make sure that we can actually give MAP. And then again, if the mice are able to kind of survive that, to go on and yes, different agents, ifosfamide etoposide or different tyrosine kinase inhibitors, different TKIs, you know, other kind of, you know, second line or salvage therapies that we commonly give in osteosarcoma. Definitely all of this could be then applied, and we could see what happens with tumors when we give other combinations of drugs as well.
Mhm. And so is part of the scope of this work to then uncover, because with all the sequencing that you're doing, to try to then correlate, you know, the well, just as kind of one big bucket, there you have the patients who are very sensitive to
Right.
MAP, and
Right.
so have recurrence, and then kind of tie those to not only the mutations, but then I guess these master regulators, so that you're able to then, and I don't know, from any preliminary work, like, do you think that you will end up with kind of these different buckets? Like, you know, you'll have a bucket of like, okay, these are this is the group that is highly sensitive to MAP, and it's, you know, it's just going to wipe them out. And they're tied to these mutations and MRs. And then, you know, maybe you might have several different flavors of groups that do develop resistance.
Yeah,
Like, is that?
you know, right now, because we're trying to really study in this project those resistant cell populations, all of the PDXs, you know, all of the models that we're looking at are from those patients that have had, you know, relapsed or recurrent disease. So, you know, we're fortunate to have a lot of, you know, initial genetic testing done on all of those patients and know their treatment background and everything. And so for this, yeah, we'll be treating those, you know, or looking at those more aggressive osteosarcoma cases that we see. You know, I had mentioned we had, you know, also looked at this kind of master regulator hypothesis in renal tumors. And what we did see between, you know, even a couple of different types of renal tumors and different kind of, you know, histological subtypes of renal tumors, we saw that a specific master regulator was kind of conserved throughout all of those cases. And so we were able to, you know, we have one specific master regulator that we target, and it's relevant for, you know, a lot of high risk renal tumors. So, you know, we'll kind of see, again, we have multiple PDX models that we can look at to see what those similarities are, again, between, say, a patient's different sites of disease or between different patients as well.
Mhm. And so I'm thinking about, like, in a clinical setting, like the timing of when you do give, you're able to, you know, identify the master regulator, and it's druggable. Like the
Yeah,
time of giving that is important, right? So
exactly. And so
clinically, like, you know, it's
that's
not
all
optimal.
going to kind of depend on what targets and what agents kind of that we see come out. And yes, of course, you'll kind of have to consider, you know, the cell cycle and when is it, you know, most important to hit, you know, a specific, you know, time in the cell cycle. And so that will have to be kind of thought out once we kind of identify what those master regulators and drugs might be. Yeah.
And so there's some work already going on to identify biomarkers of
Mhm.
high risk of relapse, and this
Mhm.
seems like it would tie into that
Mhm.
nicely.
Mhm.
So
Yeah.
were you guys, yeah, is that kind of one outcome of this as well, this work?
Yeah, I think all of that, the work that's being done and in the biomarkers definitely can all be, you know, all of this can be incorporated together, I hope. Right. Because we want to, you know, be able to you know, find something again that's going to be relevant for the most number of patients, right?
Yeah,
Yeah.
I know. Hopefully it will be like in Reno where you find like there's
I know.
one that would be really helpful.
That would
Um,
be.
yeah. And so I actually listened to a talk by Brian Crompton, who I'm
Mhm.
sure you're familiar with. He does a lot of liquid biopsy work.
Yep.
He was actually on the Little Warriors, which is also a great webinar series. And he was talking about his work on liquid biopsies. And so
Mhm.
one thing that I found was interesting is that kind of regardless of like mutation, like before even like looking at mutations, it was just high level of CT DNA,
Yep.
like kind of pointed to greater risk of recurrence, which I thought was
Mhm.
interesting because that's not even like looking at, you know, the mutation. It's just
Right.
number of the level of CTT and ctDNA. So I'm just kind of curious, actually, like how that might intersect with this. And so, is it possible that like the resistant subclones, like there's just like higher contribute to like higher ctDNA?
Yeah, so I don't know if even, this small number of, or, these small resistant subpopulations, there's even, if it's even detectable with kind of the methods that we have now. I'm not sure. But that would be interesting. Yeah, I'm not sure.
Yeah. And how many master regulate? I mean, I guess this is kind of what you're working on, but I was just kind of curious in general, like from other, like you talked about renal cell cancer, but the number of master
Yeah.
regulators.
So it's actually a fairly large number of protein regulators that we get from this algorithm, and they're ranked. So with kind of how perturbed they are, or how much they kind of influence that whole cell state. So there are some that are, it's really just kind of a rank of importance. So the ones that are at the top are probably, the most important master regulators to take out. But the list can be fairly extensive. And so we'll kind of have to, see what our output is and see which one of those and how they rank between the different tumors.
Mhm. And so it seems like could there be, in one case you might have kind of like the one key one, but there could be an instance where there might be multiple MRs that you would have to kind of knock out.
Right. And I think we know that combination chemotherapy is what's really going to be the answer. And there's, probably not a single drug that is going to be able to kind of cure, metastatic osteosarcoma. But if we are noticing over time as these tumors evolve, if they're, developing a certain kind of mutational profile, and if we can target that with different agents at different time points, kind of, and I think, Dr. Reed may talk more about this in his talk next month, but kind of similar to how we treat leukemias by giving multiple different agents at different points in the time course, to really, effectively kill those metastatic cells, or those resistant cells.
Thank you. And I just saw, thanks, Dr. Dela Cruz just added some comment in the Q&A, just kind of, yeah, add some additional commentary that Dr. Pavic's lab has identified recurrent patterns of tumor cell subpopulations across osteosarcoma patients, ongoing work to characterize these subgroups of patients and evaluate specific drugs. Okay, gotcha. So yes, so talking about those different subtypes. And Walker, do you want to take that other question?
Yeah. So the next question I ask, is it possible to do map exposure to cells in vitro and get meaningful results without the mouse model?
Can you say that again? I'm sorry, I missed it.
Sorry. It asks, is it possible to do map exposure to cells in vitro and get meaningful results without the mouse model?
I think it would be difficult to do that in cells. It's not something that we've tried. I don't think we'd probably be able as much to replicate that clinically relevant dosing that we see. So I don't know how then equivalent to, like the human doses that we'd be able to see. There's,
Okay.
we can probably treat in vitro treat at sublethal doses. And it's another way that we could, look at some of these things.
Gotcha. I have a question about the single cell analysis. So when you go and do that, how many cells are you looking at when you do that? And then like how long does that actually take? Because I feel it seems like it would take a long time.
It's a pretty long process, and yeah, Dr. Pavicic is kind of the expert that we turn to in that situation, and it's thousands and thousands of cells that we're able to look at. Yes, so it's a time-consuming process for sure.
Okay. Yeah, that's pretty crazy.
And yeah, as things get more sophisticated and our threshold of detection gets smaller and smaller, the more cells that we can see. Yeah.
Right. And so when you do the single cell analysis, are you looking at the chemo-resistant cells, or are you looking at every the whole tumor per se?
Yeah, so what we're thinking is that after the cells that we are the viable cells that we're looking at after we've given the MAP chemotherapy obviously have not been killed off
Right.
by the drugs that we've given. So we're thinking that those are likely the resistant cell populations. And if we can group those or cluster those into different subgroups that have similar characteristics, that would be helpful.
Okay, that makes sense.
Mhm.
Dr. Burke, I know your work, this particular scope of this project is focused specifically on looking at MAP-treated tumors and the resistance that kind of develops. That it might even be there before, prior to treatment, or develops during treatment. But resistance is also applicable to the targeted therapies, right?
Mhm.
So to what extent is this work applicable to just understanding resistance beyond just during MAP, but looking at how resistance might develop even with the targeted therapies?
Yeah, I think that these basic the concepts and what we're doing can definitely be applied to different agents, different targeted therapies, and yeah, so I think it's all applicable to that. Mm-hmm.
Yeah, and because again, it's always challenging too. I think in clinical trials today, because often when you have patients enrolling, they've already been heavily pre-treated and
Mm-hmm.
actually have had relapse. And it seems like in this setting, what you're trying to do is kind of to prevent the recurrence from happening in the first place by kind of aggressively targeting those chemo-resistant subclonal populations. And so how does, I'm just curious, like, again, as you think about moving forward to clinical trial, kind of
Mm-hmm.
changing that paradigm a little bit, because, again, right now, usually you get patients that are later stage, and this is something that, you want to change up front. And I know it's harder probably to start a trial, changing upfront therapy, like the kind of
Mm-hmm.
standard protocol for
Yeah.
treatment. Curious about that moving forward.
I think the direction that we're headed in is that hopefully in these patients, again, whether they're newly diagnosed or multiply relapsed, these patients that go on trials, if we're able to more frequently get tumor samples, like take biopsies and analyze them, with the techniques that we have, that will be able to kind of inform us about the different evolution of these tumors, and if there are other agents that we might be able to incorporate into treatment regimens that would effectively kind of target that. Yeah, and I think that's kind of the where hopefully things are headed. Again, the more information that we have throughout a patient's time course, the more tissue that we can analyze, the more helpful it's going to be.
Yeah, I mean, it's amazing. There's so many fantastic things that are happening in the study, even just starting with like being able to kind of give the nice map to really kind of replicate the patient experience. But it is to me like really hopeful that kind of all these new technologies like the single cell sequencing, that you're now able to identify those subclonal populations, right? Which
Right.
several years ago, we didn't even know. So the fact that you're able to kind of identify them and analyze them, I think is really a great step forward.
And
So
I think, yeah, a major barrier, has, we've been able to do the single cell sequencing for, several, years and years now, but it gets less expensive, and we're more readily able to kind of access that technology, where really, it was too expensive and millions of dollars to be doing it on every patient every single time. So hopefully we continue to head in that direction as well.
yeah, no, it's fantastic. Fantastic that the study is leveraging all of that. So thank you, and thank you for all your amazing work on this, and appreciate your being our last guest of 2024.
Yes. Happy New Year to everyone.
Yes. Yeah, on a great note. So thank you for all your work making it better for osteosarcoma patients. And more information on this and all osteobites can be found on our website at mibagents.org, at our YouTube channel, and also at your favorite podcast place. Thank you so much for supporting Osteobites, for watching, and placing Osteobites in the top 20% of Spotify video podcasts. That was pretty cool. We wish you all a wonderful holiday season, and we hope to see you back here for our first episode of 2025, where we're also going to be joined by another MSKCC superstar, Damon Reed. He's head of the Division of Pediatric Solid Tumors and chief of the Pediatric Sarcoma Service at Memorial Sloan Kettering. He also is vice chair of the Bone Tumor Committee for the Children's Oncology Group. And so he's going to be joining us in January to discuss the COG's blueprint for research on bone tumors. So we hope you join us for that. You can find our Osteobites lineup for the next few months on our website. If you have any ideas for future topics that you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Burke and Walker, for joining us today. And thank you for all of you for making time and taking time out of your day to join us. We appreciate it. And we hope to see you back here in 2025 for our first episode when we chat with Dr. Damon Reed. Thanks, everyone.